Hello and welcome to HPS Pharmacies webcast lecture. My name is Sally Drake and I'm the Clinical Communications Coordinator at HPS. This webcast lecture is on the management of nausea and vomiting, and it will focus on the different classes of antiemetic medicines available. So nausea and vomiting is a non-specific symptom associated with a range of issues. And in the case of acute nausea and vomiting, this can include gastroenteritis, food poisoning, motion sickness, medicines such as chemotherapy, surgery, and pregnancy. However, it can be a sign of a more serious medical condition. Therefore, any nausea and vomiting really needs to be investigated and the cause treated as appropriately. However, antiemetics may be useful for symptomatic relief, and their use significantly improves quality of life and may also prevent complications such as dehydration and electrolyte disturbances. And there are a number of potential pathways that can be targeted by antiemetics, including dopaminergic, serotonergic, histaminergic, cholinergic, neurokinin, and cannabinoid receptors. And the choice of agent really depends on the cause of the symptoms, the preferred route of administration, and any previous response to therapy. So the first group of antiemetics here are the dopamine antagonists. So dopamine can result in nausea and vomiting by acting on the D2 receptors in the chemoreceptor trigonome. And so these medications include domperidone, metoclopramide, prochlorperazine, and ropinirole. And these treat nausea and vomiting by blocking these D2 receptors, with domperidone and metoclopramide also having prokinetics effects, which may make them particularly useful in cases that are due to gastroparesis. And so while dopamine is involved in the development of nausea and vomiting, it also has a number of other functions within the brain. So this includes motor control, cognitive function, pleasure and reward, and hormonal control. Therefore, dopamine antagonists are associated with a range of class effects, including extrapyramidal side effects and elevation of prolactin levels. So the risk of extrapyramidal side effects is particularly high when high doses are given and when the IV administration is quite fast. And caution should be used in patients who are elderly. And in general, all dopamine antagonists should be avoided in patients with Parkinson's disease, as they can significantly exacerbate symptoms of Parkinson's. However, of all the dopamine antagonists that are available, domperidone is least likely to cause this effect, as it does not readily cross the blood-brain barrier. So domperidone is indicated for the short-term treatment of intractable nausea and vomiting from any cause. It is only available as tablets for oral administration, with the usual dose of 10 milligrams 3 times a day. This agent has been associated with some significant cardiac safety issues, including serious ventricular arrhythmias and some cardiac death. And the risk may be particularly high in patients taking higher doses, so more than 30 milligrams a day, and in those over 60 years of age. And its use is contraindicated in patients with pre-existing conditions such as prolongation of cardiac conduction intervals, significant electrolyte disturbances, or underlying cardiac conditions such as congestive heart failure. And this agent is primarily metabolized via cytochrome P450-384. And to minimize adverse effects, domperidone is contraindicated with potent inhibitors of this enzyme. So that includes azole antifungals, macrolide antibiotics, diltiazem and verapamil, amiodarone, aprepitant, and some antivirals such as ritonavir and zacinivir. And next we have metoclopramide, which is used to control nausea and vomiting associated with a range of conditions, including uremia, radiation sickness, malignancy, labour, infectious diseases, and during the post-operative period. And it can also be used for medication-induced nausea and vomiting. It's available as an oral tablet as well as an injection for IV or IM use. A typical oral dose for an adult would be 10 milligrams 3 times a day. The onset of action is quite rapid after IV administration, so 1 to 3 minutes, 10 to 15 minutes for IM administration, and 30 to 60 minutes for oral administration. And to minimise the risk of extrapyramidal side effects with this agent, it is only recommended for short-term use, so for up to 5 days. And as children are at greater risk of extrapyramidal side effects with metoclopramide, it's generally advised to avoid its use in patients under 20 years of age, and it is contraindicated in patients who are less than 1 year of age. Next, we have prochlorperazine. So this is used in the treatment of nausea and vomiting due to various causes, and is available as a tablet and an injection. The typical oral dose is 20 milligrams initially for adults, followed by 5 to 10 milligrams 2 hours later if needed. And if it's still required, an additional 5 to 10 milligrams can be given 3 times a day. And the IV or IM dose is generally 12.5 milligrams 8 hours as needed. It does have a range of effects on other pathways. So it potentiates noradrenaline, and it also has antagonistic effects on alpha adrenoceptors, histamine receptors, and cholinergic receptors. And this can contribute to other adverse effects such as orthostatic hypotension, reflex tachycardia, sedation, dry mouth, and constipation. And lastly, for the dopamine antagonists, we have droperidol. And this can be used to prevent or treat postoperative nausea and vomiting. It's available only as an injectable agent for IV or IM use. And the usefulness of this agent is really limited by its sedating tendencies and its risk of extrapyramidal side effects. So it's typically reserved for nausea and vomiting that is refractory to other agents. Our next class of antiemetics is the 5-HT3 antagonists, which are quite effective for nausea and vomiting associated with chemotherapy and surgery. So these agents block serotonin both peripherally and centrally, so in the gastrointestinal system, as well as in the chemoreceptor trigger zone in the brain. And these agents are effective in managing nausea and vomiting with cancer therapy and surgery. So the available agents are granisetron, ondansetron, pelinositron, and tropisitron. And all of these agents are thought to be similarly effective overall. However, for the prevention of postoperative vomiting, pelinositron is generally thought to be more effective than ondansetron. And when it's used for chemotherapy-induced nausea and vomiting, these agents are typically more effective for the acute symptoms rather than delayed symptoms. Overall, they have quite a favourable side effect profile. However, some of the common side effects are constipation, headache, and dizziness. These agents are available in a range of presentations, including tablets and capsules, orally disintegrating tablets, as well as injections. And next up, we have substance P antagonists. So these include aprepitant, fosaprepitant, and mirtazapine, which is only available in a combination product with pelinositron. So these agents prevent the binding of substance P to the neurokinin type 1 receptor, which is found in the chemoreceptor trigger zone. And these agents are indicated for the prevention of acute nausea and vomiting, as well as delayed nausea and vomiting associated with chemotherapy. And when they're used in the chemotherapy setting, they're typically administered in conjunction with a 5-HT3 antagonist and a corticosteroid, so typically dexamethasone. Aprepitant is also indicated for the prevention of postoperative nausea and vomiting, where it may be used as a single agent. Common side effects for this class include diarrhea, fatigue, headache, and dizziness. And it's worthwhile noting that the this class of medications do have a number of clinically significant drug interactions due to their effects on cytochrome P450. So aprepitant is found to inhibit, induce, and also be metabolized by CYP3A4 in a dose-dependent manner. And it's also a moderate inducer of 2C9. So when administered with other medicines that are metabolized by these enzymes, one or both of the drugs can be affected to cause either increased or decreased therapeutic effects or increased adverse effects. So combination with pimozide, terfenadine, esomeprazole, and cisapride is contraindicated, and caution really should be used when combined with medications that have a narrow therapeutic index. And as fosaprepitant is rapidly converted to aprepitant after IV administration, it's likely to have the same interactions as aprepitant. And nitapetant is metabolized by and moderately inhibits 3A4. So it should be avoided with strong inducers of CYP3A4, and caution is required with medicines that are metabolized by this enzyme. Next, we have antihistamines. So in the hospital setting, you would typically see cyclizine and promethazine. However, levomethazine is available on the SAS special access scheme, so you might see that around. And other agents such as dimenhydrinate are available over the counter. They're typically used for the prevention of motion sickness. So these agents can cause sedation due to their effects on the histamine receptors, but they also have anticholinergic effects, and promethazine has some anti-serotonin effects as well. So typical adult doses would be 50 milligrams IV 3 times a day for cyclizine, and promethazine, it can be given either orally or intramuscularly. However, promethazine is known as a vesicant, and deep intramuscular injection into a large muscle is the preferred method of parenteral administration. If it's given intravenously or inadvertently given intraarterially or subcutaneously, it can result in complications that can be quite severe. So this can range from thrombophlebitis, nerve damage, abscess formation, through to tissue necrosis and gangrene. And the Institute for Safe Medication Practices has issued a number of alerts in response to this issue, and it strongly advises against the use of injectable promethazine in favour of safe agents such as 5-HT3 antagonists. So here we have just a summary of the agents that are available. And so if a patient does experience a poor response to one agent, it might be worthwhile trying a medication from a different medication class. Alternatively, combination therapy with agents with different mechanisms of action could be considered. So that concludes this webinar. I hope you enjoyed this little session, and I hope you found it useful for your practice. If you do have any questions or feedback at all, please contact me directly. My email address is sally.drake@hps.com.au. Thank you again.